All right, so this is going to be talking about chapter 13, and we're going to be looking at colorectal and male reproductive tests and procedures. This is going to start on page 494 in your book if you would like to follow along. So for our introduction, our colorectal tests and our procedures are often performed to look for early detection of colorectal cancer, as well as precancerous polyps. We can also see some other less serious conditions through these tests and procedures, and that can include things like hemorrhoids, fissures, diverticulitis, peptic ulcers, ulcerative colitis, GERD, which stands for gastroesophageal reflux disease, as well as Crohn's disease. Some of our most commonly used tests, we get to go over all three of these and talk about what they are, how they work, the different prep for them. But our first one is stool-based colorectal screening test. We actually get to do this in class. You'll learn about it in just a second, but you get to take your own sample and then you'll bring it in and we'll test it. Our other two tests are sigmoidoscopy and colonoscopy. Something that we may be responsible for is advanced preparation, so letting the patient know beforehand what they need to do before they come in for that procedure. And then we also need to make sure that they understand the instructions, and we need to explain it according to their education level. So if somebody has a PhD in something, then they're probably going to understand a little bit at a higher level than somebody that lives in rural Kentucky that doesn't have a high school education. So we need to take in consideration those types of things and simplify it to where everybody can understand. Even if they are healthcare workers themselves, it does not mean that they're going to understand what you're talking about, just because there are different specialties and different levels of education within them as well. If we don't get proper prep, we might not have accurate results, so it's very important that we do get that proper prep. Okay, we're going to look at the structure of the large intestine. There's not a whole lot that you need to know about this specific portion. You should remember most of this from A&P. Hopefully, I know it's probably been a little while since you've had A&P. But our large intestine, it's divided into three main parts. And then our colon is actually divided into a few more parts. So our three main parts are the cecum, the colon, and the rectum. The cecum is that first part of the large intestine, and it's right where the end of the small intestine attaches to the large intestine. It's right there. Then we have our colon, which consists of a few different parts. Your ascending colon, your transverse colon, descending colon, and sigmoid colon. I think these are pretty easy to remember based off of, like if you look at page 495, if you take a look at that diagram, your ascending colon is the one on the left side. Your transverse colon, if you break down that term, the part in there, trans, means across or through, so this one goes across the stomach. Your descending colon is on the right, so that food and stuff is going down. And then your sigmoid colon, it almost takes on a little squiggly shape like an S does. So that's what helps me remember the order of the different parts of the colon. The rectum is located between the colon and the anus. The anus is the end of the GI tract completely. Some of our primary functions of the large intestine, main ones are absorption of water and then preparation of fecal material for elimination. Okay, next we have colorectal cancer. Colorectal cancer, CRC, is used to describe both cancer of the colon as well as cancer of the rectum. So it's not just cancer of the colon, it includes the rectum as well. This is the third most common type of cancer in the US and the second leading cause of cancer-related deaths for both men and women. It's becoming increasingly common and a lot more people at younger ages are dying from this. It usually starts from small precancerous polyps in the colon or the rectum. A colorectal polyp is an abnormal growth that protrudes from the mucous membrane of the large intestine. Detecting polyps early through colorectal cancer screening allows them to be removed before they can develop into cancer and spread to other parts of the body. Once a polyp is removed, it is examined by a pathologist to determine if it's benign or malignant, which then dictates further treatment is necessary. So if they're doing part of the screening test, like maybe they're doing a scope, either a sigmoid colonoscopy, if they see a polyp, they might go ahead and remove it and then send it off to pathology and see if it's benign or malignant just in case. If you hear squeaking in the background or running around, it is just my dog, and I apologize. Some symptoms of colorectal cancer. There's typically very few or little to none during the early stages. If it's detected and treated while patients are still asymptomatic, the patient is going to have a 90% chance of a 5-year survival. After the symptoms appear, that goes down to a 40% chance. And then when it's spread to distant organs or metastasized, it's only 11%. When this becomes more developed, you are going to see some symptoms, and these are going to include bleeding from the rectum, blood in or on the stool, a change in the shape of the stool, a change in bowel habits, general abdominal discomfort, unexplained weight loss, and fatigue, constant fatigue. Some risk factors. The cause of colorectal cancer is not 100% known. Genetics have a little bit of a play into it, and then a lot of studies now are showing that, maybe possibly some of our foods that we eat, just because everything is so processed. So studies have shown that maybe that's kind of leading to the causes of some colorectal cancers. Some risk factors. To start out, a risk factor is anything that increases your chance for developing a disease. Risk factors that can be changed for colorectal cancer, these include smoking, diet, and physical activity. So we can quit smoking, we can change our diet, and we can change how much physical activity we're doing. Some stuff that cannot be changed for risk factors include age. Obviously, we can't change our age. And then family history. We can't help who our mom or dad is, or what they have, or any of our genetics. So that's not something that we can change. If you'll flip to page 496 and you'll look at box 13.1, there's also some more risk factors within there. So you'll see for age, your risk is going to increase significantly after 50 years. For gender, men are going to have a slightly higher risk than women are. Some personal history, individuals that have adenomatous polyps have an increased risk of developing colorectal cancer. Personal or family history of colorectal cancer, if you have previously been diagnosed, or if you have somebody in your family that's been diagnosed, like a first-degree relative, so parent or sibling, you are also at more increased risk for developing it. Personal history of inflammatory bowel disease, people that have this of a long duration are going to have an increased risk. So if they have ulcerative colitis and or Crohn's disease for a long duration, that puts them at increased risk. Personal or family history of an inherited genetic syndrome. Approximately 5% to 10% of individuals who develop colorectal cancer have an inherited genetic colorectal cancer syndrome. These syndromes occur when a genetic mutation associated with colon or rectal cancer is passed down through the family's genes. Racial and ethnic background. This will have a play in a lot of different diseases, and different races and ethnicities are going to have different risk for different diseases. So for this particular one, African Americans are going to have the highest incident, and they don't know the reason for this specifically. Some other factors that are associated with a higher incidence include type 2 diabetes, smoking, moderate to heavy alcohol consumption, physical inactivity, and obesity, a diet high in fat and red meat and processed meats, and then low intake of fresh fruits and vegetables, so kind of that low intake of fiber. Some guidelines. Screening is the process of testing to detect diseases in an individual who are not yet experiencing any symptoms. So they do screening for a lot of various things. And this is one of those things that they screen for pretty early on compared to other diseases and illnesses, just because it is so common. The ACS recommends that all ages 45 to 75 years who are at average risk be screened for colorectal cancer. So people that are at an average risk, they would like it to start at 45 years of age. Individuals with certain conditions have an increased risk for developing colorectal cancer, and they should be screened at an earlier age. And some of those conditions include personal or family history of colorectal cancer, adenomatous polyps, or an inherited gene syndrome, inflammatory bowel disease of long duration, personal history of getting radiation to the abdomen or pelvic area to treat a prior cancer. Typically, once you get your first screening, they'll do it every few years, but the frequency sometimes depends on what they find in that specific screening. So I think it used to be every 3 years or so you would have to get screened, 3 to 5 years. But if they find something that looks concerning, they might change it to getting one every 6 months or every year or so. And that can vary from patient to patient. Okay, now we have stool-based colorectal screening test. This is on page 497. If you look at page 497, the box 13.2, this does have a nice little box here that shows the 3 different stool-based tests, and then it shows the visual examination procedures, so colonoscopy, CT colonography, and sigmoidoscopy. So it kind of has all of those right there together. So for these stool-based colorectal screening tests, these are used to screen for the possible presence of colorectal cancer and polyps. These require a patient to collect a stool specimen at home and return it to the medical office or an outside lab for testing. And then we are the ones that are responsible for patient instructions and education to make sure that they do it the right way, they handle it properly, they package it properly, and send it off in the right amount of time. Most of these screening tests are going to work by detecting the presence of blood in the stool. During early asymptomatic stages, most cancers and large polyps bleed a little bit on an intermittent basis. And this is because those little blood vessels in cancer or polyps are often really fragile and they get damaged easy once you pass stool. Those damaged vessels usually bleed into the colon or rectum, but rarely enough to be seen, so it's not visible. This is going to be called hidden or non-visible blood, and the actual term for it is going to be occult blood. So occult means hidden or non-visible. The patient should be instructed not to collect a stool specimen when any of the following are present, and this is very important. So diarrhea, blood in the urine or stool, bleeding cuts or wounds on the hands, rectal bleeding, and menstruation. The reason for this is because these can cause blood to appear in the stool, which can give us a false positive test result. A positive test result does not always mean the patient has colorectal cancer. It indicates only the presence of blood in the stool. The source and the cause of bleeding still has to be determined because we don't know where it's coming from. So that means that we're going to have to do further testing to be able to see where it's coming from and before a specific diagnosis can be made. Some of those different diagnostic procedures are going to include colonoscopy, a CT colonography, and then a sigmoidoscopy. I do have there's a comma after the CT in parentheses, and that's not supposed to be there, and I apologize. So it's computed tomography colonography. A negative result does not always guarantee the absence of cancer, and the patient should follow the screening guidelines, which once again are in box 13.2, and it says individuals between the ages of 45 and 75 at average risk for colorectal cancer, and then it lists those stool-based tests, it lists the visual examination procedures, and then it says individuals between the ages of 76, and 85, the decision to be screened should be based on an individual's preferences, life expectancy, overall health, and prior screening history. And then individuals older than the age of 85 no longer need to be screened. Okay, now we're going to go into the 3 types of stool-based colorectal screening. They're all pretty similar, but have a few differences, especially when it comes to what patients need to stay away from, the different patient preps, how expensive they are, what do the patients need to do. So there's some small minor differences. So our 3 types are, I can never say this word right, I think it's Guaiac fecal occult blood test, abbreviated by GFOBT. Then we have the fecal immunochemical test, the FIT. And then lastly, we have the fecal immunochemical DNA test, or the FIT DNA test. For the Guaiac, the GFOBT, this is a CLIA wave test that uses Guaiac to screen for occult blood in the stool. If you don't know what CLIA means, that's something that we're going to talk about in MedLab if you've not already been in that class with me. So a CLIA waived screening test or a CLIA wave test is something that typically we can do within the physician's office. And then it's going to be super simple, super easy. A lot of times patients can do it at home themselves. So some things that are going to be included in there are like your over-the-counter test, like a pregnancy test, or even a drug test that's over-the-counter, hemoglobin test, blood sugar, mono, flu, COVID, stuff that we can kind of do on our own, not many instructions included. The guaiac is a chemical that changes to a blue color if blood is present, and we're going to get to see that when we actually do these in class. This is designed to detect the presence of occult blood in 3 stool specimens collected on 3 different days. In class, we're only going to do 1. We're not going to do 3 different days. The purpose of 3 specimens allows detection of blood from colorectal lesions that exhibit intermittent bleeding. This is inexpensive and it is very easy to perform, so it has a lot of positives for it. Some of our patient instructions, these are very important, these are key. The patient is going to follow a special diet for 3 days before the test, all the way up until they collect all 3 specimens. So number 1, they're going to have a high fiber diet, and this is going to help add bulk to the stool. It helps promote bowel elimination, and it encourages lesions. It encourages bleeding. Sorry, that's a typo. It encourages bleeding from lesions that bleed occasionally. We're going to have a diet free of red meat, and that's because this is going to contain animal blood, which can lead to a false positive. We need to have them avoid ibuprofen, naproxen, and then more than 1 adult aspirin per day. So they're going to limit it to 1 aspirin per day or less. They need to consume less than 250 milligrams of vitamin C per day. And then they're still able to take iron. Iron does not affect the results. On page 498, there's a section called quality control, and we'll talk about this in a couple of the classes that you have with me. So quality control is used to help us get reliable and valid results. So it's making sure that our test that we're doing is working the right way and our results are going to be accurate. So these must be performed after the patient's test has been developed, read, and interpreted, and this ensures that the test results are accurate and valid. Our next stool-based screening test that we have is the fecal immunochemical test, the FIT test. This is also a CLIA-waived fecal occult blood test, and it uses antibodies to detect human hemoglobin. If you don't know what hemoglobin is, it's what gives the red blood cell its red pigment, and it helps to carry oxygen and carbon dioxide to throughout the blood. For this test, the specimen is collected by the patient, once again, and it's returned to the office for processing and interpretation. We are responsible for the patient instructions once again for collection, care, and storage. This test is more expensive than the GFOBT one. It is also more sensitive to the presence of lower GI bleeding than the GFOBT. It is not affected by drugs or food, so they don't have to have dietary modifications like the GFOBT. And then it has fewer false positive results than the guaiac one. When a FIT test is positive, the patient does need to undergo further testing so we can see where that blood is coming from. Our last stool-based screening test that we have is the fecal immunochemical DNA test. This is the newest type. This one is commonly heard. You might see it on some advertising on TV. So the brand name of it is Cologuard. It is going to be more expensive than the other, so it's the most expensive. It is not a CLIA wave test either, but it is a combination of the FIT test, and it also includes a DNA test. So like we learned, the FIT test is going to detect the presence of human hemoglobin in the stool, and then we're adding on the DNA test in there too that detects altered DNA in the stool shed from cells that may be associated with colorectal cancer or precancerous polyps. This must be prescribed by a healthcare provider, and it's going to have a kit that is shipped directly to the patient and includes step-by-step instructions. This right here is our Cologuard procedure. So this is the instructions that the patients are going to get. I did kind of simplify them a little bit-ish from what the book has on some of them because it makes it easier to look at and read. So number 1, you're going to collect an entire bowel movement in the large container in the kit. Number 2, you're going to remove the grooved probe from the collection tube. Number 3, you're going to obtain a small sample from bowel movement in a large container by scraping the surface of the stool with a probe, making sure to cover the grooves at the end of probe. Number 4, place the probe in the collection tube and seal it tightly with the screw cap. Number 5, immediately pour the preservative over the stool specimen in the large container and seal it tightly with the screw-on lid. Number 6, label the collection container and the tube. And then lastly, place the large container and tube in the shipping box and mail it back within 24 hours to Cologuard. The lab test, when it gets into the lab, it's going to test the specimen and then it sends that test result to the patient's provider, and then the provider will call back with the results. A positive test result does indicate the presence of altered DNA and or human hemoglobin in the stool. However, we can't confirm the presence of colorectal cancer or precancerous polyps once again. So it's recommended that the patients undergo a colonoscopy. And just because this is negative does not guarantee that they don't have cancer or polyps as well. So they should still continue to follow the screening guidelines. Okay, so now we are going to go over some of the diagnostic colorectal procedures. So these are what we're going to do if we do end up getting positive results, or sometimes even if it's negative and the provider just wants to go ahead and do this, then they'll perform these. So the first one that we have is called a flexible sigmoidoscopy. A sigmoidoscopy is the visual examination of the mucosa of the rectum and sigmoid colon using a flexible fiber optic sigmoid scope. This scope is going to have a tiny video camera that's attached to the end of the insertion tube, and that camera magnifies and transmits the images of the colon to a video screen so the provider can see it. It is our responsibility as the MA prior to the procedure to obtain the patient's signature on a written consent form after the doctor explains the procedure and the patient is allowed to ask questions. It is very, very key. You do not get a written signature on a consent form unless the doctor explains the procedure. Sometimes, like when I worked on labor and delivery, they would have us give the patient written consent forms, and we were supposed to go in first thing and have them sign these forms, but the provider may not have always talked to them, and we didn't know that it wasn't allowed because we were told to do it. We didn't know it was allowed until I actually quit from that job. So it's very important that you are witnessing the doctor explaining the procedure, explaining what's going to happen. You let anesthesia talk to them, and then you get their consent. Obviously, allow time for them to ask questions. That's very, very important so they understand and they're more able to be willing to do the procedure. Our purpose for the sigmoidoscopy, it may be performed following a stool-based colorectal screening test to determine the source and cause of bleeding. It can also be performed to evaluate certain patient symptoms related to colon, like lower abdominal pain, diarrhea, or constipation. Some conditions that can be detected and assessed do include lesions, polyps, hemorrhoids, fissures, infections, and inflammation. It is valuable as a diagnostic procedure for detecting inflammatory bowel diseases as well, and these are going to include ulcerative colitis and Crohn's disease. So these are some chronic inflammatory bowel diseases that don't have a cure and they are just kind of lifelong, but they can be managed with medication. A sigmoidoscopy does have certain limitations. Because it reaches only the lower third of the colon, the provider may not be able to determine the cause of patient's symptoms or fecal occult bleeding. In this situation, the provider might want to order a colonoscopy, which is going to look at the whole entire colon. If the sigmoidoscopy does detect the presence of precancerous polyps or colorectal cancer, a colonoscopy must be performed. Some patient prep for the sigmoidoscopy. I do believe, let me check really quick, but I do believe there is a table. It's on page 502, table 13.2. It has all of the patient prep for the sigmoidoscopy, and I want you guys to take a look at that, and I want you guys to read through it. So the lower third of the colon must be flushed out completely so that it is empty and free of local materials. This is called a partial bowel prep, and this is because only a portion of the colon needs to be prepared. Bowel prep is one of the most important parts of the sigmoidoscopy, and it's our responsibility for providing patient instructions on preparing the colon. If the patient does not prepare properly, the procedure is usually canceled and rescheduled because they won't be able to see what they need to. Okay, digital rectal exam. This is performed before a sigmoidoscopy. This is also abbreviated by DRE, and it's looking at the anal canal and rectum. So how it works is with a well-lubricated gloved index finger, the provider is going to palpate the rectum for the presence of tenderness, hemorrhoids, polyps, and tumors. Palpable abnormalities are viewed directly with the endoscope when the endoscope is inserted. An endoscope is an instrument that consists of a tube and an optical system for direct visual inspection of organs or cavities. The DRE also helps relax the sphincter muscles of the anus and prepares the patient for the insertion of the endoscope. So for the procedure, the patient is going to be placed on his or her left side in a position called modified left lateral recumbent position. The distal end of the sigmoidoscope is lubricated and inserted into the anus and rectum, and then it's slowly advanced in the colon until it reaches the sigmoid colon. A small amount of air is blown or insufflated into the colon through attached tubing. The reason why is because it's going to distend the lumen of the colon for better visualization. So we're adding air to make it bigger. Think of it like blowing up a balloon. We can use suction equipment to remove secretions like mucus, blood, or liquid feces that can kind of get in the way. If an abnormal lesion is discovered during the exam, the provider will perform a biopsy using a long, thin instrument passed through the lumen of the endoscope. And if you don't know what a biopsy is a surgical removal and examination of tissue from the body to determine if a lesion is benign or malignant. If a polyp is discovered, the provider may remove it and want to perform a biopsy. Okay, so the procedure continued. This is a little bit of what the MA does. So this is kind of the MA's role and purpose within the sigmoidoscopy. So the MA must prepare the patient for the procedure and assist during. So we can determine whether the patient has prepped properly and let the doctor know. We're going to ask the patient to void prior, empty the bladder, position and drape the patient in the modified left lateral recumbent position, reassure the patient and help them to relax, lubricate the provider's gloved finger for the digital rectal exam, lubricate the distal end of the sigmoidoscope, assist with suction equipment, hold the specimen container to accept the specimen if it's required. We're going to assist the patient after the exam, prepare the specimen for transport to the lab if we have one. We're going to help clean the room, and then we're going to sanitize and disinfect the equipment like the sigmoidoscope. Okay, next up we have a colonoscopy, which is very similar, but it looks at a little bit more. So a colonoscopy is the visual examination of the mucosa of the rectum and the entire length of the colon, which includes the sigmoid colon, descending colon, transverse, and ascending colon. And we're going to use a flexible fiber optic colonoscope. This scope has a tiny video camera attached to the distal end, which also, it's pretty much the same as the sigmoidoscope. It's going to help to magnify and transmit those images on a screen so the provider can view it and see what's going on. Before a patient undergoes a colonoscopy, the provider explains the nature of the procedure and any risk to the patient and offers to answer any questions. We might be the ones responsible for obtaining the patient's signature on a written consent form, which grants them permission to perform the procedure just like the sigmoidoscopy. Our purpose for performing the colonoscopy is often performed following a positive stool-based colorectal screening test. So we're going to see what that source and cause of the bleeding is. It's also performed to evaluate patient symptoms like lower abdominal pain, rectal bleeding, chronic constipation, and chronic diarrhea. This is considered the gold standard for assessing colon abnormalities. And some conditions that can be detected and assessed during a colonoscopy include lesions of the colon or rectum, colorectal polyps, hemorrhoids, fissures, infection, and inflammation. A colonoscopy is particularly valuable for the detection of symptomatic and asymptomatic colorectal cancer. An early detection of colorectal cancer leads to an earlier diagnosis and treatment, which helps increase their odds for survival. For patient prep, there is a table on page 504 that I want you guys to take a look at. So it's table 13.3, and it has all the prep from 7 days before the procedure all the way to following the procedure. So I want you to take a look at that. It's usually performed in a hospital or outpatient basis or large medical clinic. The colonoscopy is. The rectum and the entire colon are going to be viewed, so we have to flush it out completely, and this is known as a full bowel prep. This is one of the most important parts of the colonoscopy because that material, the fecal material, can get in the way with visualization, so we might not be able to see what's going on. The medical assistant may be responsible for providing the patient with instructions on preparing the colon, which includes a strong laxative and a liquid diet. The patient should be encouraged to follow the instructions exactly. If the patient does not prepare properly, the colonoscopy is usually canceled and must be rescheduled, which requires the patient to go through another bowel prep. So we need to educate them on the importance and say, okay, listen, buddy, you don't want to have to go through this prep twice. During the procedure, a sedative is administered before to cause the patient to become relaxed, sleepy, and less aware of what is taking place. And usually patients don't remember the procedure at all. Normally they don't wake up. A lot of times the procedures will only last a couple of minutes, honestly. If they find something that looks worrying, it'll last a little bit longer, especially if they have to take a biopsy. But if everything looks okay, it doesn't take very long at all. The procedure itself is very similar to a sigmoidoscopy. They're put in the same exact position, the modified left lateral recumbent position. They're going to have a DRE before. The colonoscope is going to be advanced all the way through the entire colon until it reaches the cecum. And then the provider is going to slowly withdraw the scope while carefully observing the mucosa for colon abnormalities. If there is an abnormal lesion that they find during the exam, they can once again take a biopsy and send it off to the lab. So they're going to remove it, they're going to perform the biopsy, send it to lab, and then that removal of the polyp is also going to help prevent it from developing into cancer in the future. Next up on page 505, we have male reproductive tests and procedures. So we're going to look at prostate cancer and testicular cancer primarily. So the important tests and procedures related to male reproductive health include prostate cancer screening test, and a TSC, which is a testicular self-examination, and these are going to help in the early detection of prostate and testicular cancers. For prostate cancer, first we need to know what it is. You might remember it from A&P. It is a small gland that surrounds the urethra. I remember the A&P book does usually describe it as a donut-like structure because it surrounds that urethra, so it has a hole in the middle, looks like a donut. It's located right underneath the bladder and it's in front of the rectum. It's about the size and shape of a large walnut, and its function is to secrete fluid that transports sperm. Prostate cancer is the most common type of cancer in American males and the second most common cause of cancer deaths in men, with lung cancer being the first most common. This is really important to tell the difference between, and definitely know this. For prostate cancer, it's found more often in African American men and men that have a family history. So don't be confused when we talk about testicular cancer and it has a different ethnicity that it's found in more. So prostate cancer, it's found more often in African American men. Some symptoms that occur when the cancer is more developed are going to include frequent urination, especially at night, difficulty in starting or holding back urination, weak or interrupted urinary flow, painful or burning urination, difficulty in having an erection, blood in the urine or semen, pain or stiffness in the lower back, hips, pelvis, or thighs. Just like with our colorectal cancer, we also have screening for prostate cancer. And the purpose of this is obviously we're wanting to find out if they have this at an early stage when it's more treatable. The primary screening tests for this are a digital rectal exam, which we just learned about, as well as the PSA prostate-specific antigen test. With the DRE, it's quick and simple, only causes momentary discomfort. Once again, they're going to use a glove on their finger, lubricate their finger, insert it into the rectum, and then they're going to be able to palpate the surface of the prostate through the wall, and that's because it's located in front of the rectum, so it's easy to feel. The provider palpates the prostate to determine whether it's enlarged or has an abnormal consistency, and normally it's going to feel soft, but if there's malignant tissue, it's going to feel more firm and hard. The sensitivity of the digital rectal exam is limited because the provider can only palpate the posterior and lateral aspects of the prostate gland. So sometimes they'll use combinations of the prostate-specific antigen and the DRE. Prostate-specific antigen test. This is a screening test primarily used to screen for the presence of prostate cancer in healthy men that don't have symptoms. Our PSA, this is a protein produced by cells in the prostate gland, both normal and cancer cells, and is found mostly in semen, but a small amount is also found in the blood. So this is going to be a blood test. The PSA measures the amount of PSA in the blood in units called nanograms per milliliter, or ng per ml. When there is a problem with the prostate gland, such as prostate cancer, more PSA is released into the blood. The possibility of having prostate cancer increases as the PSA level goes up. However, there's not a set cutoff value that indicates whether or not a man might have prostate cancer. Most men that don't have prostate cancer are going to have a level less than 4. A PSA level of 4 to 10 is considered borderline high, and the chance of having prostate cancer is 25%. Men with a PSA level of 10 or greater are going to have a 50% chance of having prostate cancer. The higher the PSA level they have, the more likely the cancer is present, and there can be other conditions that cause an elevated PSA level, including benign prostatic hyperplasia, BPH, which you might also hear called benign prostatic hypertrophy, which means the same thing. And then our other condition is prostatitis, inflammation of the prostate. The PSA may normally increase after things like vigorous exercise, so the patient should be instructed to engage only in normal activity for 2 days before having the blood drawn. The patient should also be instructed to not have sexual intercourse for 2 days before, because ejaculation can cause a significant increase in the PSA level. If the digital rectal exam is abnormal and or the PSA level test is elevated, further testing might be performed to determine if prostate cancer is present. To make this assessment, one or more of the following tests may be performed. We have a transrectal ultrasound, a biopsy of the prostate gland, magnetic resonance imaging, which we all know as MRI mostly, bone scan, and a CT scan, which is computed tomography. Some screening guidelines. The screening tests for prostate cancer do have certain limitations, so our DRE and PSA. Just because they get abnormal test results does not mean that they have cancer present, just like our colorectal screening test. So normal results from these tests don't mean that they can't have it as well. Treatment of a man with prostate cancer can have major side effects such as erectile dysfunction, urinary incontinence, and problems with bowel function. And there is a little typo here. I don't know if I can show you. So this part right here, the CER is not present. That's supposed to be up there, but for some reason my PowerPoint kind of messed things up. So it's supposed to say further normal results from these tests do not mean that cancer is not present. So that's supposed to be up here. I do apologize for that. All right, lastly for this chapter, we have testicular self-examination. The purpose of this is to detect testicular cancer early on. That way we can treat it, because when stuff is detected earlier, it has a very high cure rate compared to if they're already having symptoms. Testicular cancer can develop at any age, but it is most common in males 15 to 34 years of age. Most cases of testicular cancer are detected by men themselves, either by accident or just performing a TSC monthly. Certain risk factors increase a man's chance of getting testicular cancer, including a history of cryptorchidism, so this is when the testicles have not descended, a family history of testicular cancer, cancer of the other testicle, so if they have cancer in one, they have a higher chance of having it in the other, and then white race. So testicular cancer is 5 times more common in white men than African American men. So this is where I told you don't get confused. African American men are more likely to have prostate cancer, and white men are more likely to have testicular cancer. And then I included this little picture here. Actually, let me see. I think I forgot to include some things on here. So on page 506 in your book, if you'll turn to that page, 506 and 507, I'm going to read off some things really quick. At the very bottom of the page, on the right of page 506, the testicular self-examination should be performed monthly once they turn 15 years of age. The best time for them to perform this is after taking a warm bath or a shower, because that heat is going to allow the skin to relax and become soft, so it makes it easier to palpate that tissue. The most common sign of testicular cancer is a small, hard, painless lump that's located on the front or the side of the testicle. And then I included this picture here that's on page 507 that shows what a testicular self-examination is. It shows them how to do it with the steps. If you have any questions, feel free to email me and let me know. I'll be available all week. Just send me an email. It might take me a second to get back with you, but I will try to check my email in the morning and at night, possibly some through the day.